At the end of the presentation, the student will be able to discuss the challenges associated with pediatric CPR, list 6 components of high-performance CPR, describe the Maryland EMS protocol for pediatric high-performance CPR, and identify the CPR equipment available for use by the pediatric EMS champions to teach pediatric high-performance CPR. The first part of this presentation is the lecture given by Dr. Karen O'Connell on pediatric high-performance CPR. This same lecture is available on the MIEMSS YouTube page as well as on the MIEMSS EMS Online Learning Center. Following her lecture will be a presentation on the teaching equipment and resources available across the state through our Pediatric EMS Champion program.
Thank you for attending our workshop on high-performance CPR. We hope you will gain knowledge and improve your high-performance CPR skills by the end of our session together today. 16,000 children experience a cardiac arrest each year in the United States. While survival from out-of-hospital cardiac arrest remains poor for children, the past decade has witnessed an increase in pediatric survival from in-hospital cardiac arrest, with up to a third surviving to hospital discharge. Despite surviving the initial event, neurologic morbidity remains high for children suffering from cardiac arrest. Maryland EMS providers care for approximately 400 pediatric cardiac arrests per year. Between 2013 and 2017, 1,629 children suffered a cardiac arrest in the pre-hospital setting in Maryland. The majority of cases occur in infants less than a year of age, many of them from accidental suffocation from co-sleeping or without an explanation, such as SIDS. Cardiac arrests also occur in the older adolescent population. There are several factors associated with favorable outcomes after pediatric cardiac arrest. Witnessed cardiac arrest victims are close to 3 times more likely to survive than victims whose arrest was not witnessed. Those who received bystander CPR are twice as likely to survive. When cardiac arrest is due to drowning, bystanders are more likely to call for help earlier and administer CPR more frequently. Shorter duration of CPR is also associated with a significantly increased odds of survival. Those who experience more than 20 minutes of cardiac arrest have 10 times the odds of not surviving. Last, presenting in a shockable rhythm is also associated with improved survival. The most important factor associated with survival overall is the quality of BLS care. Being ready to provide the best care for children in cardiac arrest has several challenges. Pediatric cardiac arrest is a low-frequency event, and for that reason, individual providers rarely have real-time experience with CPR in children. It is pertinent to maintain one's CPR skills and knowledge, and studies show that there is a significant decay in as little as 3 months after training. Current training schedules for most healthcare providers only recommend retraining at intervals of every 1 to 2 years. So, we have come a long way in our understanding of the quality factors that optimize survival after cardiac arrest. Being a cheerleader for high-quality CPR is important, but simply cheering for Bob is not going to improve his chances of survival. The 2010 American Heart Association guidelines reordered the priorities during cardiopulmonary resuscitation, with the focus now on chest compressions first in CAB. This change applies to adults, children, and infants, excluding the newly born. Even for children and infants who suffer more cardiac arrests from hypoxia, establishing chest compressions first is the most important factor in resuscitation. The goal of resuscitation is not only for survival, but also for good neurologic outcomes. For this to happen, we need to maximize blood flow to the heart and the brain by optimizing cardio-cerebral perfusion pressure with the delivery of high-quality CPR. Chest compressions are an inefficient means of delivering adequate blood flow to vital organs, with only 10 to 30% of normal blood flow to the heart and 30 to 40% of normal blood flow to the brain being generated with each chest compression. So now that we know that CPR is inefficient at baseline, providing poor quality CPR is considered a preventable harm. So here are the 2015 American Heart Association recommendations for high-performance CPR. The first component is to compress at a rate of 100 to 120 beats per minute. The second is to compress at an adequate depth. Third is to allow adequate chest wall recoil. The fourth is to minimize interruptions with a maximum amount of time of 10 seconds. The fifth is for a chest compression fraction of greater than 80%. This is the time during CPR when you are actively doing chest compressions. The sixth is to avoid excessive ventilations. Now, let's talk about each component of high-performance CPR. First, we want to push fast, but not too fast. There are very few pediatric CPR quality and outcomes studies. But what we know from inpatient pediatric cardiac arrests is that providers seldom compress the chest at a rate compliant with the AHA guidelines. This is listed in blue. In this study, chest compressions were delivered at a rate of 100 to 120 beats per minute only 28% of the time. The majority of the time, providers were performing chest compressions at a rate too fast, so as providers, we need to take a deep breath and slow down. So how do you set the rate of 100 to 120 beats per minute in your mind as you're doing chest compressions? What often helps is to find a song that has a mean beat per minute of 110 and one that really jives with you. There are several apps that you can use. Jog FM or Fit Radio app, for example, Run to the Beat, are two that often come to mind. Some songs listed here have a mean beat per minute that can help you keep your internal metronome ticking at a consistent beat. As a provider, we can't let pride get in the way of quality care. The rules are push hard or get out of the way and let another provider assume the role. What we know from the adult data is that the harder the push, the better the chances of survival. Again, we still have to extrapolate most of our CPR quality data from adult studies and apply the same recommendations to our pediatric patients. In this adult study, cardiac arrest victims were more likely to survive to hospital admission and discharge as chest compression's depth increased. The 2015 AHA guidelines recommend that providers compress the chest at an adequate depth, which translates to, for adults, 2 inches or 5 centimeters. For children aged 1 to 13 years, compress at a depth of 1/3 the anterior-posterior diameter of the chest, which is approximately 2 inches or 5 centimeters, and for infants less than 1 year of age, excluding the newborns, to compress at a depth of 1/3 of that anterior-posterior diameter of the chest, which is about 1.5 inches or 4 centimeters. To provide chest compressions to an infant, there are 2 techniques you can use. As a single rescuer, it may be easier to use the 2-finger in the center of the sternum technique. This is easier for a single provider to transition from chest compressions to ventilations. However, the rate and depth often fall short of the guidelines. For 2 or more rescuers, the 2-thumb encircling hands technique is recommended, as it allows for better rate, depth, and consistency in chest compressions. For children, the recommendations are to use 1 or 2 hands over the lower half of the sternum. Each technique has its pros and cons. The 1-hand technique is associated with slower rates of compressions, while the 2-hand technique is associated with increased provider fatigue. The key here, however, is figuring out which technique works best for you and to get the job done well. The next high-quality CPR guideline is to allow full chest recoil between chest compressions. To do this, we need to avoid leaning on the chest between compressions. Chest compressions have 2 phases. The compression phase is associated with increased intrathoracic pressure that helps generate forward blood flow out of the heart and lungs to the other vital organs. In between compressions, we need to allow the heart to refill. During the decompression or recoil phase, the intrathoracic pressure drops and allows the refilling of the heart and lungs so that the cardiac output during the next compression is ideal. One way to measure if we are allowing for adequate chest wall recoil is by measuring release velocity. Release velocity has been directly related to improved outcomes in adult cardiac arrest. Real-time quality feedback can be used with certain monitors or defibrillators. The indicator in purple on the top bar on the monitor to the left shows the compression depth, the rate, release velocity, which is that vertical purple bar, and the perfusion performance indicator, which is the PPI indicated by the purple diamond. When the release bar is full, the provider is not leaning and allowing for adequate chest recoil. The position the provider has in relationship to the chest is important to minimize leaning. Providers should position themselves directly over the patient as best as you can, with your weight evenly distributed between your arms and legs, with your hips as the pivot point. This video will now demonstrate adequate chest compression technique in a child. This video will demonstrate chest compression technique in an infant using the two-finger approach. This video will demonstrate how to do adequate chest compressions using the two thumbs encircling technique in an infant. Next, we need to provide uninterrupted chest compressions. The guidelines call for limiting pauses to less than 10 seconds. The goal for the entire cardiac arrest event is to provide chest compressions more than 80% of the time. This is the chest compression fraction. We know that there are many tasks that need to occur during the resuscitation. However, to minimize pauses while doing these tasks, providers should coordinate their pause activities every 2 minutes. The desired pit crew style pauses coordinate the pulse check, the rhythm check, and provider swap. Every pause in chest compressions decreases the coronary artery perfusion pressure. The longer the pause, the longer it takes to regenerate that pressure. This translates to lower chances of survival with longer pause durations. In this study, just lengthening the pause from 10 to 15 seconds was associated with a 50% decrease in the rate of successful resuscitation. Longer pause durations have also been associated with decreased defibrillation success. Most pauses studied lasted between 10 and 20 seconds, which you can see here that just going from less than 10 seconds to 10 to 20 seconds drops the shock success by 22%. The last high-quality CPR recommendation is to avoid excessive ventilations. Every breath increases interthoracic pressure and impedes blood return to the heart. Hyperventilating cardiac arrest victims is common, especially in the pediatric population. To adequately ventilate, proper positioning is important because in this population, the relatively large occiput, or back of the skull, forces the neck into a flexed position when the patient is laying flat, and this occludes the airway. A shoulder roll will help align the airway so that ventilations are easy to perform. The ventilation should be low volume with minimal chest wall rise and delivered at a rate of 10 breaths per minute or 1 ventilation every 6 seconds. This video demonstrates how to perform ventilations in a child. Notice the minimal chest wall rise with each ventilation. This video demonstrates the minimal chest wall rise with each ventilation. This video demonstrates the technique of providing ventilations in an infant. This video demonstrates the minimal chest wall rise with each ventilation in an infant. This video is a side view, also demonstrating minimal chest wall rise with ventilations in an infant. Unlike in adults, we are still focusing on the ratio of chest compressions to ventilations in children and infants. For a single provider, the chest compression to ventilation ratio is 30:2. With 2 or more providers, this ratio changes to 15:2. One tip that helps with coordinating the chest compressions and ventilations with minimal pause time for breaths is to provide the breaths after the 14th and 15th chest compressions. Once you have an advanced airway in place, such as an endotracheal tube or a supraglottic airway, you can focus on each system independently. Now you will provide chest compressions at a rate of 100 to 120 per minute and 1 breath every 6 seconds. Here is a video demonstrating the coordination between teams when delivering chest compressions and ventilations using the 15:2 ratio.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 1.
Providing high-quality CPR to cardiac arrest victims takes coordinated teamwork. We are going to now talk about putting it all together so that our teams deliver high-performance CPR. High-performance CPR teams model NASCAR pit crew teams. The tasks performed by these teams are well-greased and well-orchestrated. We can do the same in our resuscitation teams. To do this, the focus has to be on teamwork. Each provider has a defined role, and these roles and the relationship to the team are drilled repeatedly through simulation. As team members, it is critical that we know the expectation of each role ahead of time. Next, we need to create an adequate physical and mental workspace, ensure scene safety, and get into the team mindset. When called to the scene of an unresponsive patient, conduct a rapid assessment and start CPR immediately. The CPR you provide should be of the highest quality, based on the American Heart Association recommendations we have reviewed thus far. The only way to maintain high-quality skills is to drill those skills. Make opportunities to practice during downtime and take advantage of available educational opportunities like you have done so today. This is a video demonstrating pit crew-style teamwork during pediatric cardiopulmonary resuscitation.
Hey, baby, baby, baby. Baby, baby, baby. No pulse. Okay. 14, 15, 7, 8, 9, 10, 11, 12, 13, 14, 15, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14,
Apply
15,
pads to patient's bare chest.
1, 2,
Plug in
3,
pads
4,
connector
5,
next
6,
to flashing
7,
light.
8, 9, 10, 11, 12, 13, 14, 15, 1, 2.
Analyzing heart rhythm.
Stop CPR.
Do not touch the patient.
Analyzing rhythm.
Shock advised.
1, 2,
Charging.
3, 4, 5, 6,
Stay clear
7,
of
8,
patient.
9, 10, 11, 12, 13,
Deliver
14,
shock
15.
now.
Stand
Press
clear.
the orange button. Shock delivered.
Shocking.
1, 2,
Pause.
3, 4, 5, 6,
Begin
7,
CPR.
8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Every provider position has a pre-assigned role or task that should be drilled frequently. These models vary across states, counties, and jurisdictions across the country, but what they all have in common is clear role assignments with tasks outlined. Teams that drill their pit crew style performance provide the highest quality CPR. For Maryland EMS, we are rolling out our high-performance CPR pediatric algorithm that will go live and into effect in July of this year. This is what the algorithm will look like in your protocol books. I'd like to go through each box so that you understand the flow of the diagram. Note as well that each provider's initial roles are listed in the box on the lower left side of the screen, and the essentials of high-performance CPR are listed at the bottom on the right. First, you will assess the patient for responsiveness in less than 10 seconds. If the patient is unresponsive, not breathing, and without a pulse, CPR should be started immediately. Here are the individual sections of the algorithm and the role descriptions that are listed again in the box on the left. Provider number 1's responsibilities are to start chest compressions immediately at a rate of 100 to 120 per minute, provide ventilations at 2 breaths to every 30 chest compressions, and to call for an AED or defibrillator. Provider 2 is in charge of helping coordinate the ventilations with chest compressions, with 2 breaths being delivered for every 15 chest compressions. Provider 2 also places an airway adjunct, suctions if needed, and attaches the AED or defibrillator. Provider 3, and others as they come, will obtain IO access, administer medications, establish an ALS airway, and provide family support. On the left side of the algorithm is a reminder that every 2 minutes of chest compressions equals 1 cycle. This is indicated by the clock. After each 2-minute cycle, there is a pause during which a series of tasks needs to occur simultaneously. This is called a coordinated pause and should consist of a pulse check, a rhythm check, shock delivery if indicated, and a rotation of compressors, all within 10 seconds. This box is located on the bottom lower right corner and reminds the provider of the essentials of high-performance CPR for pediatrics. We have reviewed each of these components already. Today's discussion and focus on high-performance CPR is not only for the purpose of improving patient survival, but also preserving good neurologic function. Practicing high-performance CPR and your pit crew style teamwork are the best methods to ensure that you are prepared to deliver the best care to the most critically ill children. Training and skills maintenance are essential. To make the biggest impact, CPR education should be simple, realistic, scenario-driven, and hands-on. Next, in order for us to know if our training and practice are making a difference, we need to consider ways to measure our performance so that we continually improve. The 3 principles of continuous quality improvement for CPR are, first, to analyze our performance so that we can refine our skills and improve our CPR care over time. A good practice to use that helps us improve each time is to debrief after every event. Ask yourselves, what went well? What could have gone better? How can I change my practice next time? A mantra we often use in pediatric resuscitation, education, and research is, if you don't measure it, you can't improve it. Thank you all for joining us today. Now let's go learn how to save a life.
In each of the 5 Maryland EMS regions, there are pediatric high-performance CPR training kits. Each kit consists of a 4-pack of infant and child CPR manikins with feedback devices, as well as 2 Laerdal Resuscibaby QCPR with sim pads. While each kit comes with appropriately sized BVMs, jurisdictions will need to provide AED trainers and any additional equipment needed to address jurisdiction-specific needs and class size. In the Preston Child CPR Maniken Kit, instructors will find 4 child manikins. Manikin heads are detached for storage purposes, 4 child BVM devices with masks, and 4 towels. Once the bag is unzipped, instructors will find the 4 heads with lungs in place along with 4 towels. Once the heads and towels are removed, instructors will now have access to the lower storage area of the bag where the 4 torsos and child BVM devices with masks are located. Additional lungs are also included in the Preston Child CPR Manikin kit if replacement is necessary. Prior to use, instructors will need to assemble the Preston Child CPR Manikins. Open up the Manikin chest by popping the tabs located at the top of the Manikin shoulders. Lift and place the Manikin head on the 2 posts, extending the Manikin lung bag over the compression plate. Close the torso and secure by pushing on the shoulder tabs until they snap into place. Reverse these steps to remove the head for storage purposes. If lungs must be replaced, remove the Manikin head from the torso by unlatching the shoulder tabs and removing the head from the 2 posts. Remove the old lungs by unhooking on each side of the head and pulling the lungs either through or out of the Manikin mouth. The Preston Child CPR Manikins utilize a combination face shield and lungs for their Manikins. The face shield lung bags have 4 dotted lines printed on one side of the bag. Fold the bag into fourths using the 4 dotted lines. Insert the folded lung bag into the mouth until it exits out of the neck of the Manikin. Grab and pull the remaining portion out. Attach the face shield tabs to the hooks located on each side of the Manikin head. Please note, this may be challenging to keep the one side hooked while attaching the other side. Once both sides are secured, lightly pull down on the lung bag to help open up the mouth hole on the face shield. From there, you will need to reattach the head to the torso by opening the chest and placing the head on the 2 posts. Align the lung bag over the compression plate. Ensure the replacement lungs are not twisted prior to closing the Manikin chest. The Preston Child CPR Manikins require 2 AA batteries to provide CPR rate feedback through lights in the left shoulder. The blue battery compartment is located behind the Manikin's left shoulder. Remove the compartment lid and exchange the batteries. Once the batteries are exchanged, secure the lid and flip the Manikin back over. All 4 lights should light up in the left shoulder area. Instructors should then perform a few chest compressions to ensure the Manikin is again working properly. In the Preston Infant CPR Manikin Kit, instructors will find 4 infant Manikins, 4 infant BVM devices with masks, and 4 towels. Once the bag is unzipped, instructors will find 2 infant CPR Manikins along with their 2 towels and 2 BVM devices with masks. Once removed, instructors will now have access to the lower storage area of the bag where 2 additional infant CPR Manikins and their respective towels and infant BVM devices with masks are located. Additional lungs are also included in the Preston Infant CPR Manikin kit if replacement is necessary. If the infant Manikin lungs must be replaced, unlatch the shoulder tabs and pull back on the infant chest. Remove the old lungs by unhooking on each side of the head and pulling the lungs either through or out of the Manikin mouth. The Preston Infant CPR Manikins utilize a combination face shield and lungs for their Manikins. The face shield lung bags have 4 dotted lines printed on one side of the bag. Fold the bag into fourths using the 4 dotted lines. Insert the folded lung bag into the mouth until it exits out the neck of the Manikin. Grab and pull the remaining portion out. Attach the face shield tabs to the hooks located on each side of the Manikin head. Please note, this may be challenging to keep the one side hooked while attaching the other side. Once both sides are secured, lightly pull down on the lung bag to help open the mouth hole on the face shield. Align the lung bag over the compression plate. Ensure the replacement lungs are not twisted prior to closing the Manikin chest. The Preston infant mannequins provide CPR rate feedback through lights in the diapers. The mannequins require 2 AA batteries. First, remove the white lid and pull out the blue battery compartment. Remove the compartment lid and exchange the batteries. Once the batteries are exchanged, secure the lid and insert back into the Maniken. All 5 lights should light up on the blue battery compartment, 4 for feedback and 1 for power. Secure the white lid back over the battery compartment. Instructors should remember to perform a few chest compressions to ensure the Maniken is again working properly prior to turning the Maniken off. In both the Preston child and infant CPR mannequins, feedback is provided on CPR compression rate. As you will see in the chart, all lights will appear when the Maniken is first turned on. This is by hitting the power switch in the diaper on the infant Maniken or by doing a compression in the child Maniken. If the compression rate is less than 60 beats per minute, a red light will appear. A solid yellow light will appear if the compression rate is between 60 to 79 beats per minute. A single solid green light will appear for compression rates from 80 to 99 beats per minute. 2 solid green lights will appear for a compression rate between 100 and 120, which is the target for instruction. If the compression rate is greater than 120 beats per minute, a flashing yellow light will appear with the 2 solid green lights. When compressions are stopped, a red light will flash. The CPR mannequins, both infant and child, will also provide a click when the student reaches the correct depth for compressions. This video will show the lights in the left shoulder area of the child CPR Maniken for rate feedback. Please note the lights change to correspond with CPR compression rate or when compressions are no longer being performed. This video will show the lights located in the diaper of the infant CPR Maniken for compression rate feedback. Instructors will need to remember to turn on the power button prior to starting compressions. The feedback lights will not automatically come on with compressions like they do in the child CPR Maniken. Please note the lights change to correspond with the CPR compression rate or when compressions are no longer being performed. Instructors will also need to remember to turn off the power on the mannequins when not in use to preserve the battery life. In addition to the Preston child and infant CPR Maniken kits, the EMSC Regional Pediatric High Performance Training Kits come with 2 of the Laerdal Resuscibaby with QCPR feedback and a SimPad with Skill Reporter software. The Resuscibaby QCPR by Laerdal is considered a moderate fidelity mannequin, and as such, the packaging and unpackaging needs to be carefully performed so the cables and connection ports are protected. Within each of the Resuscibaby QCPR carrying cases, instructors will find the infant QCPR Maniken within its own personalized blanket, a SimPad with its case, power cables for the SimPad, as well as USB connection cables for the QCPR Maniken and SimPad. Additionally, there is a towel, infant BVM device with mask, and a laminated sheet listing the kit contents and setup instructions. To connect the QCPR infant Maniken to the SimPad, the instructor will need to expose the right side of the Maniken by unsnapping the onesie snaps. The instructors will then need to connect the USB-B end of the USB cable to the Maniken port located on the right side of the Maniken. It is recommended that at that time, the instructors turn on the Maniken using the power button. Maniken power is on when a green light appears. Instructors should then attach the micro USB end of the USB cable to the SimPad. If needed, connect the SimPad to power to charge during use by plugging in the power adapter for the SimPad. Instructors may also choose to have the SimPad charged completely prior to use to reduce the amount of cords present during instruction, as the SimPad does not have to be plugged into power to work with the Maniken. Turn on the SimPad by depressing the gray button located at the top of the SimPad. The Laerdal Start screen will appear and then automatically launch the Laerdal Skills Reporter. Once the SimPad is turned on, instructors will see two options, BLS Learner and BLS Instructor. It is our recommendation to use the BLS Learner during the hands-on portion of the course. When the BLS Learner is selected, instructors can choose from practice or assessment mode. If practice mode is selected, instructors can choose type of CPR performed, 1 rescuer or 2 rescuer, CPR for teams, compressions or ventilations only. Depending on the selection, instructors will see the rate and recoil compression feedback, an accelerometer to indicate the rate of compression, and a vertical rectangle with horizontal lines that will indicate ventilation quality and volume. If hand placement is inappropriate, a chest will appear showing that the hands must be moved. When the end button is hit, a score will appear indicating how successful the student was with their CPR skills. Instructors will be able to hit each area for more information to assist with student debriefing. Instructors can get back to the main menu by hitting the BLS menu. If assessment mode is selected, a timer will appear that will begin to count down either when a student performs a compression or a ventilation. No feedback will be provided when using assessment mode. Only the timer will be visible. If the instructor ends the assessment early, it will not give a save option or provide skills results. The instructor is able to change the length of the assessment by changing the duration on the skill type prior to the start of the assessment. Instructors can choose from 1 minute to 10 minutes. At the conclusion of the assessment time, instructors will receive a prompt asking if they want to save the assessment. Instructors can enter any text of their choice into the field and hit save to view the assessment results. If instructors do not save, assessment results will not be shown. The assessment results given will provide the same feedback as shown during practice mode. The overall score will once again be shown, as well as key feedback. Instructors can then tap on the screen to dive into further feedback on overall scores, compression scores, ventilation scores, ventilation rates and volumes, compression rates, recoil and depth, hand placement, number of cycles performed, and much more. Please note the Pediatric EMS champions have had instruction on the use of the SimPads during the 2018 to 2019 rollout of the Pediatric High Performance CPR curriculum. If your EMS operational program's Pediatric EMS champion has not yet had the training, we will resume training in the summer and fall of 2021 now that more in-person activities may resume following CDC guidelines. To learn more about the Pediatric Champion for your jurisdiction or to inquire about borrowing the Pediatric High Performance CPR equipment, please contact pep@miemss.org.
California Casualty has been endorsed by the MSFA for 10 years for its auto, home, and renter's insurance. It is our honor and privilege to protect those who protect our communities. Happy 10-year anniversary to the members of MSFA. Thank you for all that you do. For more information about our program, please visit www.calcash.com/MSFA. We look forward to seeing you at various local, county, and state events.